Hi. So good to see you all. I'm an old lady, I'm going to put on my glasses. Mary is one of my mentors, and I saw she was speaking today, and I was like, man, I feel sorry for whoever has to go after her. It's such an honor to be here with you today to talk about what we can learn from taking a public health approach to bringing psychedelics into mainstream mental health care in the United States. Bear with me here. I'm going to dive into some nitty-gritty details about payment structures and access. I believe this is important simply because the existence of highly effective treatments is worthless to the people who can't get them. So let's start with the mission of public health. The Institutes of Medicine define it as fulfilling society's interests in assuring conditions in which people can be healthy. The focus on health rather than disease is a deliberate one that reflects a recognition that health is more than a product of genetics and individual behaviors, but is significantly determined by the conditions and the environments where people are born, live, learn, work, play, worship, and age. We call these environments the social determinants of health, which are themselves largely determined by structural determinants of health, meaning economic and social policies, and political determinants in health, in essence, who has power over whom and to what extent. Very little health is actually produced in healthcare, and the same is true for mental health care. The World Health Organization states that public health aims to provide maximum benefit for the largest number of people. Public health is concerned with protecting populations, which can be as small as a local neighborhood and defined by demographic characteristics, or as big as an entire country or regions of the world. Maximum benefit for everybody and focusing on high-risk populations can be complementary approaches, but as we will see with bringing psychedelics to market, sometimes focusing on one objective will come at a cost to the other. We should ask ourselves if risk or the burden of disease is concentrated in subsets of the population, will a maximum benefit for the largest number of people increase or reduce disparities? So what are the ills that we hope psychedelics will address? Post-traumatic stress disorder and depression will be the on-label applications of the first psychedelics to come to market. However, many people who have experienced psychedelics personally believe they hold potential for even greater healing. Healing from the relentless competition and extraction inherent to capitalism. That psychedelics will give us a path towards a more loving society with less racism, sexism, less isms, and more connection, caring, and mutual aid. Okay, if that's true, we would expect to see this progressive mindset reflected in the way this breakthrough therapy is rolled out. Because we all know that post-traumatic stress disorder and depression are not randomly distributed in the population. Rates of depression, anxiety, even suicide correlate negatively with income and employment. This is true in the United States and worldwide. It's true now, and it's been true for as far back as we have data. Why is this? One potential reason is called the social causation mechanism. This theory suggests that living in poverty and suffering from inequality are essentially toxic. Deprivation causes mental harm. A different potential mechanism is called social selection, where poor mental health limits financial and employment opportunities, leading to poverty. By and large, research suggests that depression, substance use, PTSD are a result of social causation, meaning the ravages of an impoverished life are responsible for observed disproportionality. In contrast, social selection plays a bigger role in conditions such as schizophrenia. Why does this matter for psychedelics? Because there is reason to fear that populations with the greatest need will be the least likely to benefit from these healing modalities. How will we pay for these treatments, and who will pay for these treatments? Is this my little slide thing? Yeah. I've heard it said that ketamine therapies are building the delivery infrastructure for other psychedelic molecules and treatments. I live in New York City, and I see the truth of this burgeoning infrastructure all around me, advertised on the subway, Facebook, Instagram, everywhere. Out of curiosity, I've spent some time visiting websites of my local ketamine options, and there are many. As a professor at Columbia University, I have really great insurance. So it would seem that I would have great access, right? Well, I do, but not because of my great health insurance, but because of my salary. From what I can see from ketamine, the rollout of psychedelics into mental health care will be a trickle-down approach. Who has the best access to ketamine? Who will have the most access to psychedelics? In all likelihood, in the most healing environments. Those who are able to pay for it themselves out of pocket. Consider this, 36% of Americans' household gross income is under $50,000 per year. 65% of Americans make households' gross income is less than $100,000. If $11,500 is a decent estimate of what a psychedelic-assisted treatment course will cost out of pocket, do we think that 65% of Americans should be spending upward of 11% of their gross income on it? Can they do so responsibly? Important to note that we are talking about household income, so the relative strain of this will be felt differently by different sized families, but I hope it is obvious that only a limited number of highly privileged, disproportionately white people will be able to comfortably pay for this care out of pocket. The next group that may have the best access to psychedelics is those who have employee-sponsored insurance through a company that is self-insured. For reference, this is about half of the employer-sponsored insurance market, about 1/4% of insured people in general. Without going too deep into the complexities of the US healthcare policy, which I love to do, self-insured companies are those that hold the risk of their employer's healthcare use. They're typically large companies with lots of employees and big coffers. Or those with a known employee demographic that tends to be relatively healthy, like a Silicon Valley startup, for example. Self-insured companies can design what they would like coverage. I almost got cut off, sorry. Let's see, where are we? Self-insured companies can design what they would like coverage to look like for their employees. Generous coverage can even be used as a recruitment strategy for talent. For self-insured companies, health insurance plans are administrative agents that manage contracts with health care providers and administer the processing of claims and billing. The employer is on the hook for actual health care spending. A reason why the self-insured may have greater access to psychedelics is because of the successful rollout of Enthea, which is the first benefit plan for psychedelic therapies. Anybody from Enthea in the house? Yeah? Well, then nobody can correct me if I say anything wrong. From what I can see, and I'm sure somebody will correct me if I'm wrong, Enthea is a health insurance rider, like a wellness plan, and for an agreed upon rate, Enthea will help connect employees to vetted psychedelic practitioners. Employers and employees will pay for the treatments based on the characteristics of their health insurance coverage, but Enthea's contracts with providers will lower costs and make finding a provider relatively simple. Enthea offers access to a patient assistance fund for those who can't afford psychedelic therapy. I'm unclear if companies who are working with Enthea also commit to covering psychedelic therapies, and if the practitioners are automatically in network or not. But regardless, what Enthea is doing will have real value added for companies that care about offering psychedelic therapy to their employees. I expect that we will see companies that have been friendly to complementary medicine and other wellness modalities engage with Enthea first. It'll be interesting to see if more conservative employers, such as city government, will follow. Next, we turn to employer-sponsored insurance, where risk is managed by the insurance company at a set per member per month rate. You probably know this, but health insurers are paid a certain amount per covered life for a contracted period. If what they are paid is more than what they pay out in healthcare claims, they are solvent or profitable. If what they are paid is less than what they pay out in claims, they're in trouble. Plans manage this risk in different ways depending on how generous employers want to be. Some plans cover almost everything. Some plans are selective about what they cover. Some plans institute tools such as prior authorizations to gatekeep services that are expensive. I've heard people argue that the effectiveness of psychedelics in the context of the high individual and societal costs of depression, PTSD, et cetera, will make coverage of psychedelic therapies a no-brainer. Why wouldn't there be widespread adoption of novel, highly effective treatments for conditions that are associated with so much lost economic potential, particularly when these conditions make other expensive chronic health conditions so much more difficult to treat? The answer is cost. It's the same reason most plans don't cover the new generation of highly effective drugs to combat obesity, drugs that people have called a cure for obesity, even though obesity is associated with enormous downstream costs. But psychedelic treatments will not likely pay for itself in the term of an annual employer insurance contract. So while I do think it is likely that most employer-sponsored insurance plans will cover psychedelic-assisted therapy, I do not see it as an entirely a given. But for the sake of thinking through the access issue with as much nuance as possible, let's assume that it will be covered. If ketamine clinics in New York City are any indication, I think that the bigger issue will be, are psychedelic clinics and providers accepting insurance? Coverage without care, when something is covered by insurance but you can't find a provider to take your insurance, is the #1 problem with access to mental health services for people with insurance. Some of you have been there, right? You've got great coverage, but nobody will see you. This problem is likely to be exacerbated in the case of psychedelics because network adequacy, or how insurers demonstrate to employers and regulators that they have an adequate network of providers to meet the needs of their covered population, is notoriously a loose measure, and it is not determined by therapeutic specialty, but by the proportion of contracted behavioral health providers available to serve a given population, usually segmented by pediatric and adult. Insurers are not required to have a certain number of providers who offer dialectic behavior therapy or cognitive behavioral therapy or psychedelic-assisted therapy. Network adequacy will only be achieved if clinics and psychedelic providers agree to enter into contracts with insurance companies. My educated guess, as a person who studies access, is that demand for psychedelic therapy will be high enough that many, if not most, clinicians will call themselves out-of-network providers, meaning that the client will pay upfront and the provider will give them an invoice if they have out-of-network benefits, which is about 30% of people in a preferred provider organization, and they will have to seek reimbursement on their own. To be clear, there are good reasons for therapists and clinics to want to be out-of-network rather than in-network. Insurance companies often want to pay less than what therapists feel they need or could earn. Yes? And I'm sure this will get me a clap. Dealing with insurance could be a pain in the ass. But out-of-network benefits are not the same as in-network benefits. Now, I will warn you, this is the part of my presentation that my wife said was boring. So if you are already bored, you can start thinking now and texting people about dinner. But I don't think it's boring at all. So we agree to disagree. For this example up here, I took an average out-of-network plan and a guess of what a full treatment course at MDMA would cost using the $11,500 from clinical trials. To make this table, I had to make some assumptions, like the Medicaid sessions were 50% of the cost, so this is rough. But I think it's important to illustrate the difference in patient out-of-pocket costs from being in-network versus being out-of-network. Out-of-network benefits have their own deductible, entirely separate from the in-network deductible. It's usually about twice as high. And while money spent in the out-of-network deductible can be used towards the in-network deductible, the opposite is not true. Money spent on in-network providers does not count towards the out-of-network deductible, so most people come into it needing to pay it. Well, most outpatient office visits for in-network providers come with a flat rate per visit, so think of preparation and integration, called a copayment, often set about $30. Out-of-network providers do not have copayments. They have coinsurance, which is a percentage of the total bill for the visit. For in-network providers, co-insurance is usually reserved only for inpatient care or diagnostic workups and is usually around 15 to 20%. It isn't totally clear to me how the medicine days will be billed. If anybody knows, I'm very curious. Even for in-network providers. But in the example on this slide, I assumed that they would be paid with co-insurance, a percentage, rather than the flat fee of $30. But I assumed the lower co-insurance network for in-network providers on the in-network example. Balance billing, which many of you may have personally experienced, which is where the provider bills the patient at a higher rate that the insurance company feels is usual, fair, and customary, is not allowed for in-network providers. They have to accept the rate agreed on in the contract. This is not true for out-of-network providers who can charge as much as they want, and patients are on the hook for all of the amount that exceeds that rate. Well, this is just an example, and these numbers are ballparks. I hope you can see the point, which is that paying for care out of network is expensive, in this case, almost as much as going on a psilocybin retreat in another country. Funding decisions for Medicare program are made at a federal level, and Congress relies heavily on the recommendations of the Medicare Payment Advisory Committee, or MedPAC. I do believe that Medicare will be incentivized to cover psychedelic-assisted therapies, simply because helping people at the end of life holds such potential cost savings for the program. The last year of life accounts for most spending in Medicare, and a good amount of that care does not extend life and is driven by psychological distress and fear of death. I think it's also quite likely that psychedelic-assisted therapy will be offered in oncology clinics where Medicare is a significant payer. Medicaid policy decisions are made at both the federal and state level. As mentioned, I'm a commissioner on MACPAC, and I think about these things all the time. Unlike Medicare, Medicaid is co-funded by states, and all but one state have a constitutional mandate to balance their budgets every year. This means that the cost of an exciting new treatment for major depressive disorder will need to be offset somewhere else that year, either in the Medicaid budget or elsewhere, such as education, transportation, libraries, or roads. State legislators are unlikely to consider that the long-term benefits of a psychedelic therapy session might result in savings later on. What makes me hopeful about Medicaid, however, is that pharmaceutical manufacturers who are willing to participate in the Medicaid drug rebate program, essentially cutting Medicaid a deal, will generally see their drug covered. I do believe that psilocybin and MDMA will be covered by Medicaid because I am convinced by the commitment to equity from the companies such as USONA and MAPS. And once again, I'm more worried that Medicaid patients will be unable to find a clinic or psychedelic therapist who accepts Medicaid. So I'm going to just go really quickly over the safety net, which are like federal qualified health centers, and they are innovators, and they've long been innovators. But so far, I don't know if anybody else has seen anything. I know I'm up. I have like just a few more things. I'm sorry. I know. I saw the other group go a few minutes late. Okay. So I'm going to say I am still hopeful. We still do have some time. Desmond Tutu famously said that there comes a point when we need to stop just pulling people out of the river. We need to go upstream and find out why they're falling in. What is the psychedelic equivalent of moving upstream? What is the psychedelic of mass and social distancing, as it were, so that fewer people need treatment for major depressive disorder, PTSD, and suicidality? Perhaps the answer will be found in Oregon. Another thing that we can do is we can be very targeted about making sure that people most in need will be the first to have access. This is happening for veterans, and we can do the same for other high-need populations. We all have a role to play in making sure that our response is targeted and that we're addressing all the barriers to access. And I have 5 things I want to say. I want to tell people what to do. And so I'm going to run through them really quick, because this is the part I like the most. Okay. We can start having conversations with FQHCs and other safety net clinics. Manufacturers can start talking to Medicaid. Clinics and psychedelic practitioners can choose to accept insurance and be in network and participate in Medicaid. I know you need to make a living, but this is such a clear and obvious way to be part of making a difference, and if you don't, who will? Psychiatrists can advocate for expanded scope of practice for nurse practitioners. Turf wars cause harm. Advocating for your nurse practitioner colleagues will make a significant contribution to broadening access. Want to see more diversity in the room, in the science, in our psychedelic therapy community? This is a problem that money can help solve. Generous foundations can gift historically Black colleges and universities funding for PhD students and postdocs and faculty who want to be in the field. And our licensing bodies, such as the Board of Psychedelic Medicine and Therapies, can avoid the pitfalls of many other licensing boards and not require a standardized exam for licensing. Why should a person who has satisfied all of the requirements within an accredited program also have to be good at standardized testing? I have more thoughts, but I'm out of time. I'm excited to be on this journey with you. Thank you all for your kind attention.
So one of the questions here, how do you see mental health parity laws impacting coverage and access to psychedelic therapies?
I can say that mental health parity laws have increased access to coverage, but more and more providers are not accepting coverage, and that doesn't help. So I do think that payment is more generous. I think it's more ubiquitous. I think that there is more of it, but the claims data suggests that more and more providers every year are billing out of network and not in-network.
So could you help us connect some dots here? So what is the relationship between what you're talking about and like the APA that just presented? How do these things connect, and how are they helpful?
So I don't know, actually. I don't know. I'm talking about a way the healthcare system works. Professional associations tend to do things like monitor quality. They become a place where people can make complaints. They advocate for policies on the state and federal level. What I've seen of APA, they seem to be very concerned with access, and so my guess is that they will be advocates for people getting better pay and having greater parity. I don't know what the ask of their practitioners would be. If I were there, I would be asking them all to accept insurance.
So having spent many years deep in the belly of the beast of commercial health insurance myself, the payment issue is really very real. And so I wonder the ability of the profession to lobby the Medicaid in particular, or Medicare, for improved reimbursement rates, therefore making it more likely that practitioners would be in network. Is that viable?
I have seen that in some places when money doesn't go up, participation also doesn't go up. I think there's a supply and demand issue, and there are not enough mental health providers for the demand, and so it makes people less dependent on health insurance when there are people who can pay out of pocket. I think that what we need to do is we need to take rich people's money and use it to subsidize health insurance for people who can't afford it.
Have you figured out the mechanism for that yet?
I like shame. I use shame really liberally.
Well, thank you so much. There are lots of great questions here, and we really appreciate you bringing your expertise to this incredibly important question of how we can get access to those who are most in need. Thank you so much, Dr. HEIDI ALLEN.
Thanks, everybody.